Katoa, tēnā koutou katoa. Welcome everybody to this webinar, and we've got 4 honours students who are willing to present their research for us tonight. So I think we'll just get straight into it. So our first presenter is Cornus Sling, and presenting on what are the trends in malpractice litigation in medical imaging technologists and sonographers, and why do they occur? So this is a scoping review. So welcome, Cornus.
Hey everyone, I'll just share my screen. Yeah, is that all good?
Yep, that's great.
Cool. Alright, hello everyone, my name is Corners, and today I'll be talking about my scoping review on what are the trends in malpractice litigation in medical imaging technologists and sonographers, and why do they occur. Before we start, I would like to acknowledge my project supervisors, Professor Nayana Paranj, Dr. Anson Chow, and Mr. Elliot Aruzo. So medical imaging professionals include radiographers, nuclear medicine technologists or NMTs, and sonographers. Radiographers can specialize in a variety of imaging modalities, including X-ray, CT, and MRI to create diagnostic images of patients' bodies, while NMTs can administer radiopharmaceuticals into patients for functional imaging. Therefore, in our study, MIT specifically referred to radiographers or NMTs. On the other hand, sonographers exclusively use sound waves to create images of various body systems. But with great power comes great responsibility, or in our case, the occasional slip-up that can lead to costly litigation. In the UK, 4% of all clinical negligence claims were radiology claims out of 10,300 claims. This made up 1% of the total value. You might be thinking these numbers are quite low, but in reality, it costed the government nearly £60.3 million to handle all of these claims. So why is this also important? Current literature is unclear about the specific errors caused by MITs and sonographers that could lead to litigation and its associated impacts. Addressing this knowledge gap can help reduce the economic burden on litigation and can help develop better protocols to improve patient safety and keep practitioners safe from litigation. Hence, the aim of our scoping review was to minimize the knowledge gap about the current trends in malpractice litigation involving MITs and sonographers, including identifying its causes. A scoping review was performed according to the JBI Manual for Evidence Synthesis and was reported using the PRISMA scoping review checklist. A protocol of this study was also published online to promote transparency. The review question was created using the PCC framework. Key search terms associated with medical imaging technologists, sonographers, malpractice, litigation, and its respective synonyms were all combined to enhance the search results. For our inclusion criteria, cases, tribunals, or disciplinary hearings were included as part of litigation to expand our scope. Additionally, studies or cases published in English and between 2018 to 2023 were also included as part of litigation in order to capture recent trends. For our exclusion criteria, we mainly excluded secondary research designs and studies about radiologists or other physicians. Electronic databases of Medline, Embase, Scopus, Westlaw Classic, and Australia were used. A variety of grey literature sources were also used to identify potentially relevant cases or other studies. Hand searching of key journals were also performed. We also contacted Australian complaint agencies working in association with APRA, coronial agencies, and Australian insurance companies for any additional resources. These were the Australian complaint agencies that we contacted, and as you can see, they are from all states of Australia. These were the coronial agencies that we also contacted, and these were the insurance companies that were contacted. For screening, confidence was used. For studies, title, abstract, and full text screening was performed by me and cross-checked by the research team. Cases underwent full text screening on their respective platforms instead, and again was performed by me and cross-checked by the research team for accuracy. Discrepancies between the researchers were mediated via a third member. For data extraction, a Microsoft Excel spreadsheet was created with the research team, piloted, and adjusted as necessary. I extracted data from the included literature onto the spreadsheet, and the research team verified the entries for accuracy. For data analysis, recurring themes were analyzed and presented using tables, graphs, figures, and narrative summaries to outline different malpractice litigation categories. Frequency counts were also performed to supplement the data. A patient journey map was created, allowing for discussions for practice and policy implications. After database and grey literature searches, 1,382 studies and 545 cases were initially identified. Only one study and 35 cases were eligible. No available studies or cases were sourced from the list of professional bodies. Only one US study was eligible, highlighting contrast media extravasation cases. Majority of our eligible cases were from the UK, followed by Australia and New Zealand. Only one case from Australia highlighting NMTs was included, making it difficult to establish common litigation trends for NMTs specifically. For radiographers, the main categories that led to litigation were unprofessional behavior, lack of competency, and errors in imaging technique. Similarly, sonographers were accused of lack of competency, operator-dependent errors, and incorrect reporting or documentation issues. Most cases highlighted errors related to the X-ray modality. Common errors performed were selecting the incorrect exposure factors, X-raying wrong side of anatomy, and omission of relevant anatomy. Figure 1 shows a hand X-ray where both the little finger and thumb were omitted from the film. Common operator-dependent errors for sonographers were performing incorrect measurements, missed pathology, omitted anatomy, and omitted measurements. Figure 2 shows how incorrect caliper placement can lead to incorrect measurements for the nuchal translucency of a fetus on baby scans. Case outcomes for MITs and sonographers were similar. Being struck off from the professional register, suspension, adjourn, and compensation were the most common case outcomes for MITs. While conditions of practice, voluntary removal, and suspension were equally tied for sonographers. Literature on patient impacts was limited. Impacts on patients were physical, financial, and emotional. Examples include one sonographer case, where parents sued for wrongful birth and recovery of costs concerning their child with Down syndrome. One radiographer case involves scanning a suspected stroke patient twice unnecessarily, where the first scan was done without a formal referral, resulting to a dose of unnecessary radiation. The study revealed that all patients who experienced contrast media extravasation later developed compartment syndrome. For one UK case involved a radiographer being accused of harassment for 2 separate instances. The radiographer ultimately had to pay compensation for the 2 separate incidents as well. Similarly, one New Zealand case involved a radiographer displaying unprofessional behavior towards a hospital cleaner. The radiographer commented on the cleaner's physical appearance and demanded a massage on site. The cleaner ultimately reported the radiographer, and the radiographer soon had to pay compensation for it as a result. And one Australian case involved a radiographer displaying misconduct towards their own patient during an examination. The radiographer inappropriately touched their female patient's chest and commented on its physical structure. As you can see, the amount of compensation varied, likely influenced by the severity of the malpractice and differences in legal frameworks across countries. Now let's discuss. While current literature mainly focuses on radiologist litigation, our paper exclusively focuses on MIT and sonographer litigation across a variety of litigation topics. These are the topics that our study mainly focused on. Obstetric ultrasound has been a frequent cause of issues in the past and even in recent years, where one recent study revealed that obstetric ultrasound litigation cases often involved wrongful birth, sexual assault, incorrect measurements, and missed pathology, where these issues were also highlighted in our study for sonographer litigation as well. While radiography errors are well documented, their link to litigation is less clear. These 2 studies identify common errors that can be performed, where some of these errors have led to litigation in our study for radiographers. A major limitation in our study was that cases settled before court were not publicly available online and could not be retrieved. We only included English publications from 4 countries, which is not reflective of global trends. Additionally, potentially relevant studies or cases published in 2024 were excluded, reducing our potential sample size. For practice implications, we developed a patient journey map, highlighting patient to MIT or sonographer interactions and to help practitioners avoid litigation-prone situations. We divided the process into 3 stages: before, during, and after the procedure. Pre-procedure actions involve preliminary checks and confirming patient details. Errors here may lead to litigation for unprofessional behavior or failure to correctly identify a patient. During the procedure, improper imaging techniques can also lead to litigation. And after the procedure, incorrect reporting or lack of competency can also result in litigation for radiographers and sonographers. For education implications, our findings can be used to inform students, reduce the litigation risk, promote best practice policies, while also guiding employers and employees in maintaining professional development and competency. For research, further study is needed, as only 1 study was eligible. Despite many media reported cases, they could not be sourced from reputable databases and were ineligible. Hence, more structured research with diverse methodologies is required to better understand emerging trends. Overall, our study has provided a snapshot of the common categories that can lead to litigation for MITs and sonographers and revealed discipline-specific errors in imaging techniques. The limited data on certain litigation topics suggests a knowledge gap, necessitating further research to validate our findings. My study has really brought home the need for me to stay vigilant in my practice, especially as I near graduation. Thank you for listening. Any questions?
Thank you, Cornus. That was very interesting. I think if we have a look in the chat, Peter's just put a note up that we will have the questions at the end. So, so like a panel discussion at the end. So if there's any questions, they'll come then. So thank you.
So Karen has a question saying, from your studies, did you discern whether patient expectations influence litigation? Unfortunately, we couldn't really find a lot of things that were involved that had patients' expectations involved. That was another limitation in our study. A lot of our cases reveal what happened to the practitioner mainly. That was the sole focus, but a lot of information was missing out from what actually happened to the patient. How did the patient influence the litigation proceedings? So yeah, there wasn't much based on my research.
Thank you. Thank you, Cornus.
Yeah.
So our next speaker is Caitlin Wilk. Welcome, Caitlin.
Thank you very much.
And or you can introduce your topic.
Yeah, certainly. Let me just get my screen up.
Yeah, you can share. Yeah, yes, it is now. Yep.
Thanks. So, hi everyone, I'm Caitlin. Thank you so much for having me here today. Today I'll be talking about my topic on the lived experience of Australian trans and gender diverse individuals with transvaginal ultrasound here in Australia. Now, before we begin properly, there's just a few definitions I'd just like to cover, just so everyone's all on the same page. So for the study, the term transgender and gender diverse, which will be shortened to trans, is an umbrella term used to refer to individuals whose sex presumed and recorded at birth is different from that of their gender identity. For the study, these identities include, among others, trans men, non-binary and fluid genders, and culturally specific identities such as Aboriginal brother boys. Now, due to these differences in sex and gender, many trans individuals may experience something known as gender dysphoria, which is a distress that can occur in relation to the individual's body or how their gender is perceived by others. To alleviate this, many trans individuals desire the use of gender-affirming hormone therapy or surgery, such as hysterectomies, to align their physical characteristics with their gender identity. And this can then result in a variety of endometrial, anatomical, or physical changes, such as the atrophy of the cervix, ovaries, or other related anatomy typically associated with females. However, a minority of trans individuals actually undergo hysterectomies, which means that many of them will still require gynecological healthcare services, such as cervical cancer screenings. Now, previous research has shown cervical cancer screening rates amongst trans individuals is much lower than those in cisgender women, currently estimated to be at 38.9% compared to cisgender 60 to 66%, which has then led to higher cervical cancer rates within this population. Now, the reason for this avoidance of these cancer screenings has been attributed mainly to gender dysphoria, either traumatic history in other healthcare examinations they had to have, or a lack of education about the procedure and whether or not they actually need it. However, research is currently non-existent on if this is similar in other gynecological scans, such as the transvaginal ultrasound, or TVS for short. So, given we found that TVS is very similar to the cervical cancer screens, namely in that it's used for disease diagnosis, it requires the exposure of genitalia to strangers, and it involves the insertion of a medical device into the vagina, we can infer that these experiences will be similar and TVS may be avoided for similar reasons. However, prior to this study, no research had actually been done looking at this experience, so this could not be said for certain. Hence, for this project, we were aiming to look at the lived experience of the Australian trans and gender diverse population of those presumed and recorded female at birth and kind of see what their experience was with transvaginal ultrasound. To do this, we used a qualitative descriptive methodology, which
You've just cut out, Caitlin.
were directly from the participants themselves. So to do this, this was the inclusion and exclusion criteria we used. And prior to actually starting any of the recruitment, we made sure we obtained ethics approval from both the university as well as ACON, which is currently one of the largest LGBTIQ health communities here within Australia. So to ensure that everything was kept ethical and the questions we are asking were appropriate, we initially piloted our interview guide with an individual who'd had pelvic floor examinations, but who had not had TBS, who was transgender. And then from that, we also did a community consultation with trans lived experience researchers from the Trans Health Research Group at the University of Melbourne. From there, once the questions had been refined and we got our final guide, we then did recruiting through the normal advertisements through both the university as well as flyers through ACON and a variety of other organizations that people would be receiving care with these kind of topics. All participants were able to register interest through an online screening survey. And from there, we, I think, had 66 viable participants to sign up. And we only did interviews with 10 just to kind of try and get that maximum variation sampling and try and capture that variety of experiences. So in total, after we'd conducted our analysis, this was the demographic of participants that we identified, majority being in South Australia, but we did manage to catch quite an age range and quite a different gender identities through some different areas there. And once we interviewed people, we used Braun and Clark's 6 steps of thematic analysis to analyze that data. In this, all the interviews were transcribed manually, and then they were coded in duplicate by myself and the research team, with any discrepancies being discussed. Just until those final themes were identified. And with these, we made sure we did this in an inference way, where we used the data to guide the themes instead of initially formalizing the themes beforehand. So in total, we found 3 main themes with 8 sub-themes. These you can see as an overview of them here, but they will be expanded upon momentarily. As just a quick summary of kind of what they are, we found that theme 1 was basically found that people didn't feel included in Current care, we found that people also didn't find it, they thought it was consensual with the current practices going on, and they also found that it wasn't informed. So in this first theme, I just sort of went with whatever service was available. Participants kind of reflected on where they chose to receive the care and the impact that non-inclusive environments had on them. So in our first sub-theme, many, like Lee, described feeling that the environments were not meant to support gender diversity. And this was primarily seen in a lack of public supportive signs or symbols, such as gender-neutral bathrooms, which led some participants to fear that they might be harassed or get in trouble for using those bathrooms in certain areas, or forms that lacked separate sex and gender options and used female-specific honorifics or terminology, such as Miss, Mrs, or Woman, which signaled that many trans individuals weren't welcome in that space. And it would make sense for access and inclusion to grow together. Participants such as ANZMRRN often raised that while they preferred inclusive practice, they often prioritized convenience, access to patient handling equipment, and affordability over inclusivity, and thus their feelings of safety. This highlights that for some individuals, they're not accessing services they automatically feel safe in when receiving these scans. Theme 2, so I could properly say, I don't want this done, covered the topic of informed consent within TVS and how often patients are not being adequately informed about the fact that the TVS involved the insertion of a transducer into the vagina, which directly disempowers their ability to make informed care decisions, as many, such as Zal above, would not have undergone this scan if they had understood what this entailed. As a consequence of this lack of education, participants often learned about the internal aspect of the TVS only after the external scan had been completed, which had led to increased pressure to complete the scan with limited time to process this new information. Given both of these sub-themes, understandably, participants indicated a preference for care from sonographers, employed dynamic consent, and explicitly highlighted ways that they could stop the scan, such as implicitly saying no or squeezing a hand. This was captured here in 2.3, where, as highlighted by Sebastian, when this approach was used, participants felt actively involved and less like they were just someone having something uncomfortable done to them. When this was used, this increased their discomfort, and some participants identified that this also helped lessen feelings of gender dysphoria. In the final theme, participants described the role of inclusive care and ways that sonographers could make them feel more comfortable during their actual treatment. So in our first theme, participants explained how there was a perceived lack of sonographer education around trans healthcare and the anatomical changes that can come and occur from testosterone, such as that atrophy and the pain that it can cause, as mentioned previously. And this typically presented itself in inappropriate questions from the sonographer, such as, when did you have your vagina created? Or assumptions about the reasons why sonographers couldn't get images, such as with Marcus here, when it was assumed he hadn't drunk enough water and hadn't followed the instructions given, when they realized afterwards it was because the reproductive organs had atrophied from their testosterone. This can be seen further in our second sub-theme here, where participants also described having staff attitudes vary based on their appearance, with those who dressed more feminine reporting they were not taken as seriously. Interestingly, however, those who reported more masculine appearances typically had no issues with staff attitudes towards their appearance, which, as highlighted by Sebastian, this kind of removed the burden from him of feeling the need to explain or justify why he was in the room or why he was in an area where he might be receiving the scan. And our final theme, it didn't take any longer being inclusive. Participants expressed how sonographers could provide that more inclusive care through being conscious of their language as well as good bedside manner. For being conscious of language, this included using patients' affirmed, otherwise known as chosen name, avoiding gendered language or terms such as us girls or us women in conversations, and asking participants for their preferred terminology during TBS examinations. As noted by Percy above, when care like this was used, it was seen as being inclusive and respectful, which made the examination relaxing, more comfortable, and able to be completed much easier than before. Thus, in summary, key takeaways I'd hope you take away from today is that current sonography practice is perceived as being unsafe, uninformed, and non-inclusive to trans individuals. However, it can be improved through 4 simple steps. The improvement of inclusive... I'm sorry? Sorry, is it all right if I still go, or is that time?
I think someone's got their mic on. Can
No worries.
everybody
Okay, thank you.
please just turn off your mics? Thank you.
All right, thank you. So clinics need to aim to improve their documentation and signage to be more inclusive of the language used, so people can feel more comfortable. Recommendation 2, informed consent guidelines need to change to include more information around the timeliness and what information is actually provided to patients prior to their attendance at the appointment. Sonographers should also aim to improve the communication around the withdrawal of consent and how patients can communicate that. And they should also aim to improve their education on trans healthcare and anatomical changes, which is needed both at the university level and in primary practice. As with all studies, the study does have several limitations. Firstly, self-selection bias may be present due to the fact that this was a voluntary study that people could choose to take part in, which means that there will generally be an underrepresentation of individuals who may have had significant gender dysphoria or distress from TBS. This also limits the ability of those who were able to access internet, so maybe limiting for those in remote or low socioeconomic groups. There was a lack of standardization around the amount of time from a patient's first TBS to the interview, compared to if this was like a standard TBS that they'd had before. So kind of identifying that difference between if it's a first or a routine one would also help clarify a bit more of those findings we had. And data saturation was also not achieved just because this is rather a large heterogeneous population. So we didn't think it would be achievable with this. So from here, future research needs to consider the impacts of cultural, socioeconomic, and educational factors. Thank you very much for listening.
Thank you, Caitlin. I think there were some questions in the chat that we'll address at the end. So thank you very much. That was very interesting. Okay, Juno, Kim. You there, Juno?
Hi there.
Hi.
Good. All right, everyone. Nice good afternoon. Good evening almost. I'm very excited to share with you my research findings for the project entitled "What are the current clinical applications of artificial intelligence in point-of-care ultrasound?" So, whilst a lot of you may have heard of what AI is, not a lot of you may know what POCUS or point-of-care ultrasound is. Well, it is a type of ultrasound that is performed at the patient's bedside or in a non-radiology setting, and it aims to examine a specific type of clinical query. However, it does not aim to replace traditional forms of diagnostic ultrasound. Those types of scans are reserved for sonographers to perform. POCUS is a great tool in the clinic. Because results are available immediately, it can accelerate care and triage processes, and that can further facilitate patient treatment on the spot. However, it is currently greatly limited by training. It is very difficult for non-imaging professionals to learn POCUS, and the results depend heavily on the operator's skill, making it go underutilized in the clinic today. This is where AI comes into play. By automating a lot of POCUS features, it aims to make it easier. In fact, applications that guide a novice user on how to move the probe, whilst indicating the quality and producing results like ejection fraction and stroke volume, already exist on the market. Well, that sounds great, but so what? Well, although it is true some of these applications have been commercialized, clinical trials underlining their clinical utility are very limited. And many benefits of these devices, although have been postulated, the field is still in its infancy. And whilst a few review articles do exist on the topic, they all have a narrow focus or are unstructured. To address this research gap, we aim to answer two questions. Firstly, how is AI being applied into POCUS, and how is AI POCUS being utilized in the clinic, with a single research question of what are the current clinical applications of AI in POCUS. Let's move on to those methods. Our research was conducted in accordance with JBI's Manual for Evidence Synthesis for scoping reviews and was reported using the PRISMA scoping review extension. For our selection criteria, we included all humans and human volunteers whilst excluding any non-human participants. We included anything to do with clinical applications of AI in POCUS whilst excluding computer science, education, and in silico studies. We included all study designs whilst excluding review articles, editorials, expert opinions, abstracts, and any non-English texts. We consulted Medline and Base MCare Scopus, Web of Science, and the first 10 pages of a Google Scholar search. Through the PCC framework, we identified AI point-of-care ultrasound as being our context and concept. And through identification of these terms, we made up a lot of synonyms to be able to search and make the search strategy more robust. We searched for white papers in manufacturer websites, and these manufacturers were identified through press releases through Google searches that were unstructured, referring to a list of FDA-cleared AI devices that was freely available on the internet, and identifying device names during abstract and full-text screening that we may come across. Screening was conducted on covidence. We started off with title and abstract screening, followed by full-text screening. It was conducted by 2 investigators independently, with a third to resolve any conflicts. We extracted common concepts and trends onto a Microsoft Excel spreadsheet, identifying any trends and performing quantitative analysis to create graphs. Let's move on to those results. We identified 1,444 records in total and ended up including 33 into our final review. Now let's answer how AI is being applied into POCUS. It was most frequently used in the cardiac, followed by the lung region, and applications such as biometry measurement, abnormality detection, and probe guidance were the most common in literature. Let's discuss what they do now. Biometry such as left ventricular ejection fraction, left ventricular outflow tract velocity time integral, as well as the collapsibility of the inferior vena cava could be measured automatically using AI, as well as bladder volume. Abnormalities such as B-lines, which are image characteristics of lung pathology in point-of-care ultrasound, as well as hip dysplasia and breast lesions could be identified automatically as well. Features like probe guidance, quality assurance, and automatic image acquisition, as you've seen before in this little animatic, can be performed as well using AI. And labels of images can be performed automatically, and vessel compression states can be analyzed in the case of deep vein thrombosis studies. Now, let's answer how AI POCUS is being used in the clinic. It was most frequently used in the acute care setting, followed by the non-acute care. 12% of studies involved use of AI POCUS on volunteers, another 12% on low resource setting. Meanwhile, 21% of the studies did not specify the clinical setting that AI POCUS was used in. We identified some advantages and limitations of AI POCUS. It is able to improve the accessibility and usability of POCUS through AI by making things easier for novice users to use. It is able to expedite patient care and management by reducing the time of individual scans, and the accuracy in the real world is acceptable for clinical use when compared to things like standard of care ultrasound or other diagnostic modalities. However, poor POCUS images cannot be interpreted by AI, and poor diagnostic performance was also reported for patients in specific disease states, especially those ones in really poor disease states. Performance, although it was acceptable, is typically poorer than standard of care diagnostic methods. Now let's discuss these findings. Well, we found that the cardiopulmonary AI POCUS applications were the most common, accounting up to 71% of all sources that were included in our review. These were likely developed in haste to compensate for the needs of the COVID-19 pandemic, and this was also a time where the FDA deregulated its strict regulations, enabled in order for those applications to come into the clinics. Other applications were not as common, likely as they are not needed, or a clear clinical need has not been seen for them yet, or likely they are still in testing and were removed from the scope of our study. AI POCUS was most frequently used in the acute care setting where non-AI POCUS is already well established in. In this setting, the role of AI seems clear, to reduce training barriers. However, we also saw an emergence of AI POCUS in the non-acute care setting, where non-AI aided POCUS is typically not used. This is because GPs and specialists are usually not POCUS trained. However, because AI POCUS requires minimal training, it could have a future role in non-acute care settings as well. In the low resource settings, there is a severe lack of trained professionals. In this setting, AI POCUS can support screening and triage processes and maximize resource allocation to allocate scans to patients that actually need it. These were some limitations of our research. AI concepts such as machine learning and deep learning were not investigated in depth, and any algorithm that was labeled AI was included without any validation of whether they could be truly classified as artificial intelligence or not. Our study also had a low generalizability. This is because we included such a wide variety of clinical settings, body regions, and AI applications, and we cannot make a generalized statement about any one of them. This is the current state of AI POCUS. Its infancy brings many challenges. Most AI POCUS research is not performed within clinical scenarios, and we had to exclude a lot of in silico studies, and that just means that they cannot reflect true real-life scenarios per se. Clinical studies do not measure the patient outcomes as their endpoint, aiming to focus only on the diagnostic performance of these devices. AI still requires good images to perform analysis. So what should we do next? Well, we must simply perform more real-world research that elucidates the utility of AI POCUS within the clinics. Furthermore, this can be used to inform implementation pathways and reporting guidelines that can inform future best practices. In conclusion, we mapped the literature of current clinical applications of AI and POCUS. AI is able to automate and simplify POCUS tasks, and by extension, the simplification can promote the use in its various settings. Future research must justify its development and dissemination in the future. Thank you very much for listening.
Thank you, Juno. Another interesting presentation. So we'll move on to our last presenter. And if people who are online, please pop any questions into the chat and we'll ask them at the end. So Cherry is in. Yeah.
Hi guys, my name's Cherry and today I'll be sharing my research project on assessing pancreatic fat and its correlation with liver fat in suspected MASLD patients using advanced deep learning techniques from MRI images. So before we start, I would like to acknowledge all the other authors who contributed to our research, including John Pablo, Nirusha, Newman, Yasmin, Enes, and Sergio. So to start with some background information about the pathologies, MASLD is the metabolic dysfunction associated steatotic liver disease, which is the chronic accumulation of liver fat with metabolic dysregulation. Pancreatic steatosis is the excessive fat accumulation in the pancreas, and it can be a predisposition to pathology such as pancreatic carcinoma, diabetes, and pancreatitis. There could be possible correlation between these two pathologies in individuals with obesity or metabolic disorders such as insulin resistance. However, there have been ongoing arguments because of their separate pathophysiological processes. Therefore, the relationship between these two remains unclear. So in order to quantify organ fat, we can perform biopsy and histological examination, which is the most accurate approach, but invasive and potentially harmful to humans. The most accurate and reliable non-invasive approach is chemical shift encoded MRI, CSC MRI, which we can calculate the proton density fat fraction PDFF to estimate fat by separating the water and fat signals. So from this equation, we can see that the CSC MRI signal is affected linearly by the water and fat proton densities, and it is affected non-linearly by the confounding factors, the R2 star, which is the 1/T2 star decay, and the field inhomogeneity. So to estimate the PDFF, the current gold standard approach is the iterative graph cut-based algorithm using 6-echo acquisition. The issue with that is the long breath hold time required, which is typically 10 to 15 seconds per breath hold. So recently, deep learning models have been developed to estimate the PDFF and consider the confounding factors. So it can separate the data into water and fat only images, as well as the field inhomogeneity and R2 star maps. So previous studies has proved that deep learning models like the unit architecture has a good agreement with the graph cut, the gold standard. Multi-decoder water-fat separation network. The multi-decoder net is a unit-based network using multiple decoders to facilitate output of different components. So it is proved that it has an improved estimation of PDFF, R2 star, and field inhomogeneity compared to UNet. So recently, our team has developed another deep learning model, the nonlinear variables neural network, the NLVNet. It only estimates the nonlinear components, the field inhomogeneity, and R2 star. So we can calculate the linear components, the water and fat maps using least square methods afterwards. So our research aim is to evaluate the accuracy of the 3 deep learning models for quantifying PDFF for MRI in the pancreas. The secondary aim was to investigate the relationship between the fat amount on the liver and pancreas. So we considered abdominal CSE MRI from 209 subjects, with 189 of them were suspected MASLD based on their ultrasound findings, and 20 of them were healthy volunteers. The table on the left shows the scan parameter of the MR data we acquired, and the table on the right summarizes demographics of our subjects. So we quantitatively measured the PDFF estimation by manually locating the region of interest in the right hepatic lobe, as well as in the pancreatic head and body. So in order to assess the accuracy of the deep learning models in the pancreas, we first acquired the PDFF estimates for the pancreatic head and body for each method, including the 3 deep learning models and graph cut in both 3 and 6 echo images. And then we compared each method against a 6 echo graph cut reference. So we performed the following analysis to test for the correlation, bias, and significant differences. So there are linear regression, Spearman rank correlation coefficient, Blunt-Ullman analysis, and Friedman test with post-hoc test. To investigate the relationship between hepatic and pancreatic steatosis, we compared the PDFF estimates of the liver with the pancreas using the graph cut method and the best performing deep learning model. Again, linear regression and Spearman rank correlation coefficient were performed, and Wilkinson test was performed for the significant differences. So moving on to the results. So to look at the performance of the deep learning models to estimate pancreatic PDFF from a 6 echo images in the pancreatic head, the NLV showed the strongest correlation with the reference, as well as the lowest bias and the narrowest limits of agreement. All the 3 deep learning models showed no significant differences to the reference method. In the pancreatic body, similarly, NLVNet still showed the strongest correlation. However, the multi-decoder net showed the lowest bias and the narrowest limits of agreement. Similarly, none of the methods were significantly different to the reference. Moving on to the 3 echo images, in the pancreatic head, the unit showed the strongest correlation, whilst the multi-decoder net had the smallest bias and narrowest limit of agreement. Significant differences were found in between the reference and NLVNet, 3 echo graph cut, and UNet, but not the multi-decoder net. In the pancreatic body, it was similar to the 6 echo results, where NLVNet had the best PDFF agreement to the reference, as well as having the smallest bias and narrowest limits of agreement. Again, none of the methods were significantly different to the reference. Moving on to the results for the correlation between pancreatic and liver fat, using the 6 echo graph cut acquisition, we found a poor correlation between the liver and pancreatic head, as well as the body. Significant differences were found in between just the liver and pancreatic head, as well as between the liver and pancreatic body. Similarly, in 3 echo images using graph cut, poor correlation was found in between liver and pancreatic head and body. However, significant differences were found in just between the PDFF of the liver and pancreatic head, but not in the pancreatic body. As NLVNet had the closest results to the reference, we consider only this method for our correlation between the pancreatic and liver fat. In the 6 echo images, we found a similar results to graph cut, where we found a poor correlation between the liver and pancreas. Similarly, significant differences were found in between liver and pancreatic head, as well as the body. In the 3 echo images, however, we found a moderate positive correlation with the pancreatic head. Weak correlation was found in between the liver and pancreatic body. Similar to the 3-echo graph cut results, significant differences were found in just between the PDFF of liver and pancreatic head, but not in the pancreatic body. So from our results, in the 6-echo images, we can see that the NLV-net outperformed the UNIT and multi-decoder net. So this suggested that using different decoders for R2 star and field inhomogeneity can improve the accuracy of PDFF estimations. The advantage of using the NLV-net when compared to the multi-decoder net is the reduced network size, as it only estimates the R2 star and field inhomogeneity, but not the water and fat signals. From the 3-echo results, we can see that the NLV-net and the multi-decoder net outperformed UNIT and the 3-echo graph cut. This means that this could be an alternative clinical approach to the PDFF estimates, while we can minimize the acquisition time, shortening it from the 6 to 3-echo acquisition, and we can reduce motion and blurring artifacts, which helps to maintain an accurate PDFF estimation. So our study found no evidence to support the correlation between the liver and pancreatic PDFF measurements. This could be due to subjects had only as suspected MASLD and their pancreas status was unknown. It also can be due to subjects had MASLD, but they can present without pancreatic steatosis, because MASLD is just one of the risk factors, but not the only contributor. So our study suggested that MASLD and pancreatic steatosis have distinct pathophysiological processes. Therefore, separate risk management and treatment plans are required for each condition. So limitations of our study included the unknown medical history of subjects. Therefore, we were unable to determine associated risk factors such as obesity for MASLD or pancreatic steatosis. A high BMI does not necessarily indicate a high body fat mass and distribution. On the other hand, biopsies were not included in our research, which is the gold standard technique for measuring organ fat. Therefore, future studies could incorporate the biopsy data with CSC MRI PDFF estimations for a definitive assessment for the correlation between liver and pancreatic fat. Future validation of the deep learning models, especially the NLV-net, would be helpful to strengthen the evidence of the robustness for translation to the clinical practice. So we can do that by using a different and larger sample size, as well as validating the R2 star, which is beyond the scope of our project. So in conclusion, our research showed that advanced deep learning models, including NLV-net and multi-decoder net, can accurately measure PDFF of the pancreas. And the NLV-net showed a strong correlation and minimal bias compared to the gold standard, the 6-echo graph cut. No significant correlation was found in between liver and pancreas PDFF estimates. Therefore, MASLD and pancreatic steatosis are not necessarily linked. That's the end of my presentation. Thank you.
Thank you, Cherry. So that brings us to the end of our presentations. I think there are a couple of questions in the chat. If we did the first one. So to Caitlin, there's a question here. Curious to how you ensured your 10 interview participants offered diversity of experience. Do you think you can?
Was it all right if I share my screen quickly?
Yeah, sure. Yeah, definitely.
I do actually have something that addresses and sort of explains kind of the reasoning and how we diversified patients. So this is kind of the process we went through with recruiting participants, and in the 66 valid responses we had, what we kind of did is we read through them and then tried to diversify them on gender expression or identity, location, whether they had used testosterone or not. And that's kind of the process we went there with, trying to diversify those 10 participants as much as we could from the responses of interest.
Right. Oh, good. Thank you.
Okay.
And then there's another one here. Oh, is this no? Do you know if the ASA have a position on this subject?
I did want to ask a clarifying question with Karen. Was that in relation to the informed consent topic or in relation to the transvaginal ultrasound in transgender patients? Sorry.
Thanks for that. Hit the wrong button then. I was more thinking about the position on being inclusive in imaging transgender individuals.
Yep. So at the moment, as far as we're aware of, we couldn't find any such statements. We did look at both the Australian Sonography Association and the Australasian Sonography Association, and then a secondary one whose name escapes me at the moment. And in relation to both of them, we couldn't find anything currently that kind of addressed anything with that. No, so I don't believe they do at this point.
Actually, that's really useful to know. Thank you. Perhaps they should after this research.
Yes,
Yeah.
yes, definitely. It would go a long way.
Definitely, yeah, sounds like it would. Okay, I think this question is for you, Juno. Great that AI may help in developing countries or geographic regions with poor healthcare. Does AI work with single issues, i.e. probe, movement or measurements, etc.?
All right, thanks for your question, Karen. I just wanted some clarification as well. Did you refer to issues as in what AI is able to do, or so
Yeah,
in terms of like probe movement or quantifying biometry on its own and things like that?
yeah, you've got that absolutely right there. So can it do multiple skills? So you've mentioned almost training with probe movement. You're talking about biometrics and things like that. Can it do both? Or is it a single issue AI and you need a different AI to do other things?
Well, our scope didn't really include, as we described, that we didn't really look deep into what kind of AI models were used to achieve these sorts of features. But what we know is that these corporations are combining many features into one, so novice users are able to use it very easily. So in the animatic that I shared with you earlier, if I can just share my screen as well. So it's labeling images, and these green bars are indicating the quality. And down here, it's just telling you how to move the probe, and that's finally calculated the biometry. So yes, individual packaged solutions are able to address many of these features at once. And on the other hand, smaller kind of more novel solutions seem to be able to only do one thing, like measure biometry or only really guide novices, because they're not yet at the level of commercialization. So they're kind of so yeah, generally the more mature they are, the more things they're able to do is kind of what I've found.
Yeah, that's fascinating and makes each one more useful. Thank you.
No worries, thank you.
Okay, and then a question here for you, Cherry. Would I be right in thinking that your research showed the ability to reduce scan times for certain suspected pathologies?
It's not really for certain pathologies, it's more for the technique itself. So our technique is actually a bit different to the normal CSC MRI. Well, it is the same for the MRI scan itself, but we can apply some post-processing, such as like the more well-known ones called the Dixon methods, where we can separate the water and fat. So it's pretty similar technique where we normally would use a technique called graph cut, and we have to use a 6-echo acquisition. So our research is trying to push towards a 3-echo acquisition, so we can shorten the scan time for this technique, the water fat separation technique, rather than scanning for a certain pathology.
Okay. And Peter's got a question for you too, Cherry. Will the application of AI save time for MRI data acquisition in your study?
Yes, so the way it can save time is that it can produce a similar result to the current graph cut, the reference method. So if we can validate the deep learning models to make sure it can produce that PDF estimates that is up to the standard, we can use as 3 echo acquisition rather than a 6 echo acquisition. So we can reduce to a shorter scan time as well as a shorter breath hold time. So it will be easier for the patient and also have a more accurate estimates, because if we do require long breath hold and there are blurring artifacts, it can actually cause mismap and result in a less accurate PDFF estimation.
Mm. And then how applicable were your findings to other centres?
I think it's more a specialized pathway. So I've talked to some private clinics and they don't really do this water fat separation techniques, but I've talked to some techs at like a larger public hospital, the metro ones. They actually do these for patients who want to have their like water fat separation to look at their organ fats. And it's very good at monitoring their like organ fats for long term because it doesn't require radiation dose at all. So I think it's more applicable towards the biggest like public sites that they would do water fat separation and using MRI to quantify organ fat.
Right, thank you.
Thank you.
And thank you to you all, Cornus, Caitlin, Juno, and Cherry, for very fascinating research that you've all been doing. And I'm a radiation therapist, so you presented it in a way that even I could understand. So well done.